In December 2019, there was a cluster of pneumonia cases in China. Investigations found that it was caused by a previously unknown virus, now named the 2019 novel coronavirus. In this video, we'll take a quick look at what's currently known about the virus. Keep in mind that this is a new virus, and what's known about the virus now might change in the future. Coronaviruses are a large group of viruses. They consist of a core of genetic material surrounded by an envelope with protein spikes. This gives it the appearance of a crown. Crown in Latin is called corona, and that's how these viruses get their name. There are different types of coronaviruses that cause respiratory and sometimes gastrointestinal symptoms. Respiratory disease can range from the common cold to pneumonia, and in most people, the symptoms tend to be mild. However, there are some types of coronaviruses that can cause severe disease. These include the Severe Acute Respiratory Syndrome coronavirus, first identified in China in 2003, and the Middle East Respiratory Syndrome coronavirus that was first identified in Saudi Arabia in 2012. The 2019 novel coronavirus was first identified in China. It initially occurred in a group of people with pneumonia who'd been associated with a seafood and live animal market in the city of Wuhan. The disease has since spread from those who were sick to others, including family members and healthcare staff. There are many cases at present, and the disease has spread within China and also to a number of other countries. So, where did the virus come from? It's known that coronaviruses circulate in a range of animals. Sometimes these viruses can make the jump from animals to humans. This is called a spillover, and could be due to a range of factors such as mutations in the virus or increased contact between humans and animals. For example, MERS-CoV is known to be transmitted from camels and SARS-CoV from civet cats. The animal reservoir of the 2019 novel coronavirus is not known yet. How is it transmitted? The exact dynamics of how the virus is transmitted is yet to be determined. In general, respiratory viruses are usually transmitted through droplets created when an infected person coughs or sneezes, or through something that has been contaminated with the virus. People most at risk of infection from the novel coronavirus are those in close contact with animals, such as live animal market workers, and those who are caring for people infected with the virus, such as family members or healthcare workers. So, how does the disease present? Well, from what is known so far, there can be a number of symptoms ranging from mild to severe. There can be fever and respiratory symptoms such as cough and shortness of breath. In more severe cases, there's been pneumonia, kidney failure, and death. The mortality rate is not known yet. How can we tell whether someone is infected? The infection can be diagnosed by a test called PCR, or polymerase chain reaction. This test identifies the virus based on its genetic fingerprint. There's currently no specific medication for the virus, and treatment is supportive care. There's currently no vaccine to protect against the virus. Treatment and vaccines are in development. How do we prevent transmission of the virus? This new virus currently has a limited geographic spread. However, there are a number of standard hygiene practices that have been recommended to protect against infection and further spread. These include covering your mouth and nose when coughing or sneezing with a medical mask, tissue, or flexed elbow. Avoiding close contact with those who are unwell. The appropriate use of masks and personal protective equipment, especially in a healthcare setting. Washing hands regularly with soap and water or alcohol-based hand rub. Actions that can be taken to prevent infection from an animal source include avoiding unnecessary unprotected contact with animals, washing hands after contact with animals or animal products, and ensuring that animal products are cooked thoroughly before they're consumed. It's important to stay home if you're feeling unwell, but if you have a fever, cough, and difficulty breathing, seek medical care early and share your previous travel history with your healthcare provider. That's a quick look at this emerging infectious disease. Given that this outbreak is evolving rapidly, what's known about this virus can change. Please check the websites below for the most up-to-date information.
Hi, my name is Alice Simniciano, and I work in infection prevention and control at the World Health Organization. Today's course will focus on infection prevention and control for COVID-19. The course will provide information on what facilities should be doing to be prepared to respond to a case of an emerging respiratory virus, such as the COVID-19 virus, how to identify a case, and how to properly implement IPC measures to ensure that there is no further transmission to healthcare workers, patients, and others in the healthcare facility. The training is intended for healthcare workers and public health professionals as it is focused on infection prevention and control. It contains 3 modules. The first, as I mentioned, will deal with preparedness, readiness, and infection prevention and control. The second will go into a little bit more detail about the novel coronavirus, its epidemiology, risk factors, and signs and symptoms. And the module 3 will go into the standard precautions, transmission-based precautions, and the WHO recommendations for COVID-19. We're going to start with Module 1. This is Preparedness, Readiness, and Infection Prevention and Control. The learning objectives of this module are to define infection prevention and control and its role in the context of preparedness, readiness, and response. Preparedness for outbreaks is part of a larger process known as the Principles of Emergency Management. It begins with prevention and mitigation. These are strategies that can help a facility prevent and reduce the impact of an emergency. The next step is preparedness and readiness. These are actions that should take place before an emergency. And once the emergency happens, there's response. These are the activities in reaction to a known or suspected event. After response, we go into recovery. This is where facilities should evaluate the prevention, mitigation, preparedness, and response efforts. Facilities should seek to return back to normal and build back better, meaning they should learn from their emergency response. So what is preparedness in healthcare? This is the knowledge, capacities, and organizational systems developed by governments, response, and recovery organizations, and communities and individuals to effectively anticipate, respond to, and recover from the impacts of likely imminent, emerging, or current emergencies. These actions will take place before an emergency and increase a facility's ability to respond when the emergency occurs. This should happen at all levels, national, regional, and facility level. So why? Because preparedness is an integral part of health system strengthening, it is crucial to health emergency disaster risk management. So therefore, inadequate IPC measures may lead to transmission to patients, staff, visitors, and within the community. This is when infectious disease outbreaks can be a result of external and internal factors. Many times, healthcare is impacted as a result of a new pathogen, something that we have not seen before or is new to the region. For example, this has happened with MERS-CoV and Ebola. Or it can be the spread of an organism throughout multiple countries, leading to an epidemic or pandemic. This means a larger number of cases of an infectious disease. Hospitals that have not put adequate measures in place to prevent and control infections may amplify or add to the epidemic by allowing transmissions to patients, staff, and visitors. These individuals who are potentially exposed in the hospital may increase transmission within their communities, making the epidemic more difficult to control. So infectious disease emergencies tend to bring infection prevention and control practices into the spotlight. Many outbreaks in the past have revealed breakdowns in IPC practices, even in institutions and countries that we assume to have had strong practices. So what is readiness? This is the capacities and the systems that should be in place to enable a rapid, effective response in case of a health emergency disaster, and to be ready to aggressively contain the event before further spread. There are 8 pillars of the public health response in readiness. The first is country-level coordination, planning, and monitoring. The second, risk communication and community engagement. And then we go into the surveillance, epidemiologic investigations, rapid response, and case investigation. Next is the points of entry into the country or health facilities. The national laboratories, infection prevention and control team, and measures put in place by this team, the case management, and the operations support and logistics, including contingency plans and funding mechanisms. These slides go into a little bit more detail about each of the pillars of readiness. So the first one, as I mentioned, refers to the multi-sectoral and multi-partner coordination mechanisms that support the preparedness and response. This is when you should be engaging with national authorities and key partners to develop a country-specific operational plan with estimated resource requirements for COVID preparedness and response, or preferably adapt existing pandemic preparedness plans, such as an influenza one if it exists. This is also when you should be conducting initial capacity assessments and risk analysis, including mapping of vulnerable populations. You should also be beginning to establish metrics and monitoring as part of the evaluation systems that will assess the effectiveness and impact of these plan measures. The second goes into establishing an incident management team. So this is where you're including rapid deployment of designated staff from national and partner organizations within a public health emergency operations center, or equivalent if you have available. This is where you identify, train, and designate spokespeople. You engage with local donors and existing programs to mobilize resources and capacities to implement the operational plan. You should also be reviewing regulatory requirements and legal basis of all potential public health measures. Here, you also should be monitoring the implementation of SCOOP based on key performance indicators in the SRP and produce regular situation reports. The third part is where you should be conducting regular operational reviews to assess the implementation success and assess the epidemiological situation and adjust operational plans as necessary. Here, you should be conducting after-action reviews in accordance with the IHR policies as required. And in terms of the COVID outbreak, this is where you should be learning from the existing plans, systems, and lesson learning exercises to inform future preparedness and response activities. So what is infection prevention and control? Well, IPC is a basic requirement for outbreak preparedness and a critical element of readiness. It should be an ongoing activity undertaken by the national program and by the IPC focal points, IPC team, and committee at the healthcare facility level. It is a scientific approach with practical solutions designed to prevent harm caused by infections to patients and healthcare workers. It is grounded in principles of infectious disease, epidemiology, social science, and health system strengthening, as well as rooted in patient safety and health service quality. So who is at risk of infection? Well, everyone. Infection prevention and control measures can protect you as the healthcare worker, can protect your patients, and protect your family and the community at large. Some of the IPC goals in outbreak preparedness are to reduce transmission of healthcare-associated infections, to enhance the safety of staff, patients, and visitors, to enhance the ability of the organization or the health facility to respond to an outbreak, and to reduce the risk of the healthcare facility from amplifying the outbreak. The core components for effective IPC programs in all contexts is displayed here, surrounded by the multimodal strategies. This figure provides a visual representation of the 8 core components of infection prevention and control, and highlights how the guideline recommendations interconnect with each other. The outermost layer addresses the multimodal strategies, which are key to effective implementation. And effective IPC programs must be based on the implementation of all core components. If no IPC knowledge, system, organization, and resources are in place, it is unlikely that a country or a healthcare facility is able to respond effectively to an outbreak. Since 2017, WHO has made available the guidelines on core components of IPC programs at the national and acute healthcare facility levels. These are a number of supporting documents and implementation tools. And in 2019, the minimum requirements for IPC core components were released as the minimum measures that need to be in place at both the national and facility levels. These are just the starting point on the journey to full implementation of the full requirements outlined in the core components. Thus, the minimum requirements represent the starting point for undertaking the journey to build strong and effective IPC programs. They should be in place for all countries and all healthcare facilities to support further progress towards full implementation of the core components. These slides go through some of the specifics of the minimum requirements of the core components. Core component number 1 is that there is a functional IPC program in place at the national level with at least one full-time trained IPC focal point and a dedicated IPC budget. At the facility level, this means that for primary care, there is one trained IPC link person. At the secondary care level, there's one trained IPC focal point per 250 beds with a dedicated time and budget. At the tertiary care level, this means that there's one full-time trained IPC focal point per 250 beds with a dedicated time and budget, as well as a multidisciplinary IPC committee and access to a microbiology laboratory. Core component number 2 refers to the evidence-based national guidelines that should be in place at the national level, adapted to the local context. And at the facility level, these are SOPs, at least on the standard precautions and basics of transmission-based precautions. At the secondary and tertiary care level, this means that there are SOPs not just on the basics and the transmission-based precautions, but additionally also on surgery, prevention of endemic hospital-acquired infections, and occupational health. Core component number 3 refers to the education and training, that there should be national policies that all healthcare workers are trained in infection prevention and control, that there is a national curriculum, and that there is monitoring of this IPC training effectiveness. At the facility level, this includes IPC training for all clinical frontline staff and cleaners upon hire, but also regularly, annually, and in specific IPC training for IPC focal points. Core component number 4 refers to the national technical group that is responsible for developing plans for healthcare-associated infections, surveillance, and IPC monitoring. At the facility level, this means that hospital-acquired infection surveillance is not just a minimum requirement, but should also follow the national plans. At the tertiary care level, this means active surveillance of hospital-acquired infections and antimicrobial resistance, as well as feedback as part of a core activity of the IPC program. Core component number 5 refers to the multimodal improvement strategies. These should be implemented for IPC interventions at all levels. At the facility level, in primary care, the multimodal improvement strategies should be in place to implement priority IPC measures. These are hand hygiene, injection safety, decontamination of medical equipment, and environmental cleaning. At the secondary care level, the implementation of all standard and transmission-based precautions and for triage. At the tertiary care level, it includes all of those above, as well as for specific types of healthcare-acquired infections, according to the local risk and epidemiology. Core component number 6 refers to the national technical group at the national level that is responsible for IPC monitoring, developing plans and recommendations, and indicators, and systems training. At the facility level, for primary care, this means monitoring of IPC indicators based on the IPC priorities. At the secondary and tertiary care level, this means a dedicated individual responsible for IPC monitoring and timely feedback, as well as having hand hygiene as a priority indicator. Core component number 7 refers to the workload, staffing, and bed occupancy levels. At the national level, there should be plans in place for these. At the facility level, there should be systems for patient flow, triage, and for the management of consultations. At bare minimum at the primary level, these should be in place to optimize staffing levels, and facilities must undertake assessments of facility-appropriate staffing levels to determine what is appropriate for them. At the secondary and tertiary care levels, there should be systems in place to manage the use of space and establish standard bed capacity for the facility. There should be no more than one patient per bed and at least 1 meter between the edges of the beds. To optimize staffing levels, facilities must undertake assessments of their appropriate staffing levels. Core component number 8 refers to the built environment, the materials, and the equipment necessary for IPC programs. At the facility level, for patient care, this refers to patient care activities that should be undertaken in a clean and hygienic environment. Facilities should include separate areas for sanitation activities, decontamination and reprocessing medical equipment, and have sufficient IPC supplies and equipment for providing IPC measures. At the secondary and tertiary care level, Facilities should have sufficient single isolation rooms or the ability to cohort if appropriate. What is the role of the IPC focal point, team, or committee? As an IPC focal point, your first responsibility is your knowledge. You need to have a good understanding of IPC and the strategies needed to reduce risks and be prepared for outbreak situations. This is acquired through face-to-face or online courses, which you can participate during your academic study, trainings, or readings, with experience, research, and networking. IPC requires continuous learning. At the healthcare facility level, the IPC components that need to be in place are the infrastructure, the policy, the SOP development, as well as an assessment of its current state of IPC, its preparedness and readiness activities. At the IPC committee level, they should be participating in response and recovering activities, participate in surveillance and monitoring of hospital-acquired infections or emerging threats, responsible for patient management, and education of healthcare workers, staff, and patients and visitors. So now we have reached the end of Module 1. Thank you for listening. You can now continue to Module 2, where we will be diving into more coronavirus-specific information. Thank you.
Hello, my name is Peter Graaf. I'm the Director of Special Initiatives at the Health Emergencies Program here in Geneva. As we have already learned in Module 2, WHO has released a practical guide for UN country teams, the operational planning guidelines to support country preparedness and response. This guide is intended to provide immediate support to governments and partners in implementing their COVID-19 country plans. And this plan will be operational between now and April the 30th. The country guidelines are structured along 8 key pillars of the public health response. Pillars are operationalized by actions to be taken to enhance country preparedness. The focus today is Pillar 1, country-level coordination, planning and monitoring. With this video, we will describe the actions to be taken within this pillar. This is relevant at country and sub-country level for governments, UN country teams as well as partners. The goal is that, after watching this video, you will be able to conduct your own assessment using the WHO online planning tool for COVID-19. In Module 2, we presented high-level actions and recommendations of Pillar 1, emphasizing the importance of activating national public health emergency management mechanisms. This includes planning, operations, logistics, and finance in full cooperation with partners. National action plans for health security and pandemic influenza preparedness also need to be activated. Let's now take a deeper look at the practices. There will be 3 levels of preparedness in coordination, planning and monitoring, starting from basic, level 1, to sustainable, level 3. At level 1, countries should ensure that the national level coordination mechanism is established between key ministries and partners across all sectors, and that this coordination mechanism is convened in a timely manner. This is a key political forum to ensure that all stakeholders have a common understanding and vision of the preparedness and response to COVID-19. By nature, as an emerging virus originating from zoonotic reservoir, and given its scale, with a public health emergency of international concern declared on January the 30th, this event is multi-sectoral and requires coordination mechanisms at all levels to ensure the success of the global response led by the UN system. The global strategy should be translated into a country-specific preparedness and response plan with estimated resource requirements, or preferably adapted, where available, from an existing influenza pandemic preparedness plan. The country SPRP is based on a risk analysis and developed with national authorities and key partners. In addition, attention should be brought to conducting initial capacity assessment and risk analysis, including mapping of vulnerable populations. Already at this stage, the basic mechanisms and metrics to evaluate the effectiveness and impact of planned measurements should be initiated. Monitoring is an integral part of program implementation and should be linked to the specific objectives defined in the country plan. At level 2, an incident management team, or IMT, is required to establish preparedness. This implies the rapid deployment of designated staff from national and partner organizations within a public health emergency operations center, or equivalent if available. The Public Health Emergency Operations Center is part of a public health emergency management program of risk analysis, preparedness, response and recovery. Its 5 essential functions are 1. Management, 2. Operations, 3. Planning, 4. Logistics, and 5. Finance and administration. Additionally, spokespeople need to be designated and trained within the IMT structure. The IMT will ensure that the operational plan is implemented, including engaging with international or local donors and existing programs to mobilize and allocate resources. The IMT will further detail roles and responsibilities for the Ministry of Health and other response agencies, sectors and jurisdictions at the various levels in the response organization, including private sector and NGO organizations. The preparedness and response actions for COVID-19 should be developed and implemented in accordance with the scope of federal, state, tribal and local statutory and of regulatory authority, as well as through state and/or federal declarations of emergency. Review of regulatory requirements and legal basis is therefore fundamental. Under the IHR, or International Health Regulations, governments are entitled to implement public health measures to protect the health of their populations during public health events, respecting 3 golden rules. Measures must 1. Be based on scientific principles and evidence. 2. Respect human rights and fundamental freedoms of travelers. And 3. Not be more invasive or intrusive than reasonably available alternatives. When such measures significantly interfere with international traffic, such as by preventing, delaying or refusing entry to international travelers or goods for more than 24 hours, countries are obliged to provide the public health rationale to WHO within 48 hours of implementation. The IMT is also responsible to monitor the effectiveness of the operational plan and measures, as well as to assess their social acceptance. A list of key performance indicators is provided in the Strategic Response Plan as a basis for monitoring key aspects of the implementation. At level 3, when coordination, planning and monitoring is sustained, countries should conduct further review of operational success and gaps based on the monitoring system, the KPI metrics, and ensure that issues are brought to the attention of the relevant authorities in a timely manner and to adjust plans and resources as needed. All exercises and live activations should be followed by an after-action review, providing actionable recommendations, identifying areas for improvement and, when necessary, implementing corrective actions. It is important that lessons are documented to inform future activities. Now that you have watched this video, you should be able to describe each action in country-level coordination, planning and monitoring, and be ready to assess whether each has already been or needs to be implemented at country or sub-country level. It is important to keep in mind that the actions presented in this video are a guide and should not, and I repeat not, supersede existing national guidance and plans. It should be used to rapidly adapt existing relevant national plans and accelerate national preparedness. For more information, you may access the operational planning guidelines in the additional resources section of the training platform. You are now ready to begin the assessment using the WHO online planning tool for COVID-19. Thank you for watching this video.